Synopsis on thoracic epidural technique. Outline. We're going to briefly talk about anatomy, about approaches. Midline, paramedian, paraspinous. While we're talking about paramedian, we discuss standard paramedian technique without ultrasound. Then we switch our attention to perfect positioning, surface marking based on palpation only, take a break, then go to surface marking and use of ultrasound for epidural. We will overview the standard technique with ultrasound. Again, it will be paraspinous approach with ultrasound. Quickly talk about identification of epidural space and standard confirmation of correct placement, and finish with adjunct technique to confirm epidural space when situation is more muddy. So let's start from anatomy. Low and high thoracic are relatively similar to lumbar spine, but mid-thoracic, and it means T5 to T9, something like that, is different. So we see prominent downward angulation of spinous process around 45-65 degrees. We see more narrow interspinous space. The space between spinous process is much more narrow. Look at this one. We see that interlaminar space can be completely obscured when we look at spine via AP view by the base of spinous process vertebrae above. So this is projection of interlaminar space, but we do not see it. We may have a little bit of a glimpse of interlaminar space right here. The tip of spinous process of vertebrae above, so right here it's vertebrae 7, is somewhere at the level of lamina or vertebrae below, and we're going to use this fallen mark based technique. But those relationships are not very consistent, so you can see here is somewhat okay, but on another level maybe not, and that's why we're going to use ultrasound for better determination. So let's talk about approaches. There's 3 major approaches for thoracic epidural. It will be your midline, paramedian, and paraspinous. Paraspinous is kind of a subset of paramedian, but we decided to kind of separate it. So let's talk about midline approach. You just insert the needle in the midline between tips of spinous process above and below, and advance needle via interspinous space toward the epidural space. So those are our spinous process that we palpated between those spinous process in midline. So needle will go between those in interspinous space and eventually going to end up in epidural space. So advantages, widely taught and familiar, and everyone has plenty of experience with midline approach for lumbar epidurals for obstetrics. There's much less cognitive load than alternative, like paramedian approach, for example, because there's only one plane in 2 dimensions. Dimension 1 is depth, and dimension 2 is upward angulation. There's a potential for good ligament engagement from the start. Remember the supraspinous ligament, interspinous ligament, and finally ligamentum flavum. And so with the midline approach, we, especially when it's kind of a deep, we have this, little trick feeling supraspinous ligament as a sign that we are in the middle. There's a high chance to place needle tip in the middle or, let's say, center of epidural space, not into the lateral recesses of epidural space, as may happen with novices when they start with paramedian approaches. And because of all of that, it's commonly the first choice approach in lumbar spine and lower and higher thoracic, meaning T9-12, T1, T4, in a regular, straightforward cases, easy cases, easy patient. But there are some disadvantages, especially in mid-thorax, T5, T9. So we're gonna split this disadvantage into sagittal plane. So you see the image, right? And here are those disadvantages. So upward angle could be very steep in mid-thorax. You see how steep this angle, more than 45 degrees, almost 65 sometimes. This angle varies at different levels. So he is probably, 65, he is somewhat 45, and it's difficult to predict. The space becomes very narrow. See how narrow the space is? And on top of it, it's frequently irregular shape and occasionally can be curved. So look here. This space is impossible to negotiate with a straight needle. This space is impossible. This space is impossible. So it could be very difficult to do true midline approach. On top of it, there's some problem with axial plane. So needle tip may inadvertently deviate from true midline. So this is our axial view, thoracic vertebrae, midline, and needle can deviate, and why it's important and why it happens. So first, there's several reasons why it happens. It could happen with normal spine if you started with a wrong needle trajectory, not perpendicular to the skin, like we show in the previous image, right? Right here, we say it's not perfectly perpendicular to the skin. Another one is due to the wrong entry point. Maybe you started a little bit off midline to begin. It can happen if you have what I call crooked spine. There's two options here. You either can have spine vertebrae that is rotated or bended, or you can have just deviated tip of spinous process. And it's kind of difficult to appreciate because we don't see through the skin. And those last two may be difficult to spot, and the deeper the epidural space, the higher the chance of these errors. And small errors on angulation or on entry point magnified at a distance. And so that's what it happens. So right now, if you look on this illustration, it seems to operators that needle was perfectly midline based on this spinous process and perfectly perpendicular to all plane. But you can see that right here, it came out of interspinal space. And that will result in false loss of resistance if you use loss of resistance as an endpoint. And if you look at this image, same way, it looks like started very nicely, but because there's a little bit small rotation of vertebrae, right here it was a deviation of a tip of spinous process, here rotation of vertebrae, and needle would end up in this little pocket of fat, and this also will result in a false loss of resistance. So that's why we prefer for mid-thoracic region of spine paramedian approach. So let's talk about paramedian approach. So we already talked that a midline approach, especially in a sagittal view, is frequently what I call mission impossible. There's no way you can negotiate the space. So the idea of paramedian approach is to bypass at least most, sometimes almost all interspinal space. So that's the same patient, but now we scan it not through the midline but paramedially. And this is the image. You see pretty decent laminas and pretty decent interspaces. And now when we don't have this constraints of spinous processes, we have minimal problems with this so-called bone-free windows in sagittal view. And we can use the whole spectrum of angles. So like here you see needle will pass and here will pass. So any angle from here to here in a sagittal view will work to negotiate this space. While in the previous slide you saw almost none of them will work. So that's an idea of paramedian approach, and there's two planes, and it makes it a little bit more difficult because of that, but those are two planes, axial and sagittal. So we start about 1 centimeter from midline at the level of spinous process of vertebrae above, right? And we have two angles, inward angle and upward angle. And again, we have a lot of freedom here because we don't constrain ourselves with the spinous processes. So this upward angle could be, from almost 0 to very little, like 15 degree, compared to previous approach when we have to do very steep 45 degree angle in a narrow space. But what is important, we still try to end up in a midline. So we start off midline, but we want to end up again in the middle of epidural space. So on top of it, most technique of paramedial approach requires so-called safe landing on the lamina that follows by control walk toward interlaminar space. And that's excellent because walking off the lamina adds confidence in predicting depths of epidural space. And that's our walking. So we'll land here on the lamina. We do, in this particular case, a little bit of walk horizontally, medially, and then we walk up vertically toward interlaminar space, toward epidural space. And this incremental walk on the bony surface negates the need to precisely guess this upward or inward angle from the start. We can just start with, no angulation at all, or with mild angulation, and then by walking find our optimal angle to get into the space. So let's talk about this classical paramedial approach and technique. So in details and steps. So first, you enter 1 centimeter lateral at the level of most prominent part of spinous process of vertebrae above. And we advance needle 90 degrees to all planes. So this is a picture. We start 1 centimeter lateral to most prominent part of spinous process vertebrae above, and we advance 90 degree in axial, or basically 0 inward angulation and 0 upward angulation. And when we advance, we feel the bone. We call this safe landing on the lamina, and it allows us to sample the depth to lamina. So in this particular case, we see 5 centimeters deep. So it's actually kind of a pretty common depth, usually somewhere from 3 to 5. Then we would pull this needle back almost to the skin, and while we do that, we make sure that we don't change the angulation. Angulation stay same, again, perpendicular to all plane. Next, we would add this inward angle, in this particular case about 30 degree inward angle. Even so, this picture probably show not 30 degree, this picture show about 15 degree, but it says 30, right? And we advance this needle until we hit bone again. And this time, depth will be expected to be slightly less due to shape of lamina and spinous process. So this was our first safe landing spot, and this is our landing after second pass. So now when we have this inward angle established, we will continue walking up until this is walking up and up and up by dropping our half of the needle and adding some upward angle until we walk the needle over the edge of the lamina and engage into ligamentum flavum. When we feel that we engage in ligamentum flavum, we would remove stylet and either hanging the drop if you do hanging drop technique, or connect loss of resistance wrench. And that's how it looks. Here it took 4 little steps. So that was a classical paramedian approach for thoracic epidural. And one more time, we were starting at the level of spinous process, most prominent, about centimeter lateral, and our initial angulation for safe landing was 0. No inward, no upward angle, or you can say perpendicular to all planes. So there's some variation on this classic technique. They could be on the level. So instead of here, it will be a little bit higher or a little bit lower. Or it could be a little bit more lateral, from centimeter to 1.5 to even 2 centimeters from midline. Also, instead of doing initial no angulation, we can start a little bit with the inward angle and upward angle from a very beginning. And of course, you can walk the way we described before, first horizontal, then vertical, or you can go straight diagonally from landing spot up and medially. So does it really matter, all this variation? So eventually, you're going to end up again in the middle of epidural space, no matter where you start, right? And most of the time, it doesn't matter. It depends on this kind of a window of opportunity, right? But there is some exceptions. So occasionally, starting too high and too medial with initial 90-degree angulation result in misalignment of possible needle trajectory and excess of this bony interspace, even after most optimal walk. So some people call it double fulcrum phenomenon. So if you look at this picture, we come kind of very medial and very high, right? And you go perpendicular to all planes. So right now, half of the needle overlap the tip of the needle. So with this first landing here, no matter what we walk later on, we cannot squeeze this needle into interlaminar space. While here, we start at the same interspace, we just look from a different point. We start a little bit more coded and more lateral. And from a very beginning, add a little bit of inward and upward angle, and you see how much bigger is the space and how easy it would be to walk over this needle into epidural space. So that's what we talk about, using this a little bit more coded and more lateral entry point for tougher cases, right, to avoid this double fulcrum. And this illustration have kind of a side view sagittal cut of this double fulcrum phenomena. So let me explain. Those are, for example, our laminas, sagittal kind of a cut. This is skin, right? And the dotted line is our first pass. We touch the bone, we pull back, and we redirect it in advance again. So this point of entry would be our first fulcrum. Over each we just move our needle when we pull back and redirect. And so as you see here, if we start too high, we actually can get into the problem with this second fulcrum or double fulcrum, edge of this lamina. So here we will not be able to negotiate this narrow bone-free window. We're gonna be jammed right here. So in order to fix it, we have to start a little bit lower. So here is example again, our first pass, we pull back, we drop our hub down, and needle went straight through the space. But again, if you are doing too much down insertion, you might actually hit the second fulcrum right here, and you cannot advance this into epidural space anyway. So that's kind of a explanation of this double fulcrum. You can read a little bit if you pause it. That's what just I explained. And again, the point is that occasionally in difficult cases it does make sense to start a little bit lower and on the lamina and a little bit lateral, right? So is there any problems with Paramedian approach? Yeah, there is problems, and again, problems mostly in the axial plane, because we said we don't have much problem in the sagittal plane because we're outside of interspinous space. But we have issues with uncertainty of this inward angle. We can undershoot, we can overshoot, while we want to be in the center. And missing the center is a problem, right? Because it's probably associated higher, high association with a wet tap because space is usually smaller here. Unilateral epidural because catheter would like to come out through the intervertebral foramina. And occasionally, we can actually cross on the other side. And when you cross in midline, then you get false loss, and you can completely have a failed epidural, right? So to avoid this problem, we recommend to use Paraspinous approach. And what is the Paraspinous approach? It's kind of a best compromise between midline and paramedial. So the idea is that you insert your needle just a hair lateral to the lateral edge of spinous process, so about 5 millimeters from midline, and keep your inward angle minimal. So instead of 30 degree, as we showed before, it should be 5-10 degree, while you still utilize what we call comforting walk over the bony surface until sliding into the space and engaging into ligamentum flavum. So if it looks like that, so start very close to the spinous process and have minimal inward angulation. So that solves problems of uncertain inward angle while keeping all other advantages of paramedian approach. It also much easier cognitively, easier to visualize. You don't need to guess this inward angle. If you think that there is not much of a difference with the midline approach, you kind of are right, because the difference between sloppy midline approach, especially when you use palpation of a bone or walk over a bony surface of a basic spinous process, it's absolutely right. It's very, very kind of a close. So you have kind of advantages of both technique. So, but nothing is perfect. So what is the problem with Paraspinous approach? And that's a problem. Chance of wet tap or even spinal cord injury, if you don't do it right, on the first pass when you try to land on the lamina. And I will explain you why it happens and how to prevent it, but that's why we call this first landing in the lamina safe landing, right? And that's why when we do paramedial approach, we start not close to spinous process, but 1.5 centimeter from midline, and it will be right here, what I call wall of bones. And we start with a 90-degree angulation, so you don't accidentally end up in the middle. By the way, you can also go accidentally and end up in a lung or cause pneumothorax, or parotibial space. So let's see how we can fix this. So we will use ultrasound. So as we said, if we use a landmark, we just feel the spinous process, this one, right, for paramedian approach, and we move 1.5 centimeters. So you never end up in an interlaminar space on the first pass. You always end up on a bone, right? But if we use landmark technique and we use paraspinous approach, so that means this line instead of that line, and let's say we use this interspace. Better, even more prominent is here. So in this interspace, spinous process of vertebrae above, position right at the level of the lamina. But in this interspace, it's actually almost close to interlaminar space. So if you go here, you can cause this injury. So how you can solve the problem? So instead of relying on landmark and relationship between spinous process and the lamina, you actually use ultrasound and visualize the lamina itself and visualize interlaminar space. That will outline the safe area. Right here is safe, right here is safe, and then will allow you to place your needle in the lamina safely and solve all those problems. So let's see clinical variation. So this is easy spine. We have pretty wide open interlaminar space. The spinous process quite narrow from tip to base, and spinous process far apart from each other. So you can, in this particular space, you can use any probable approach. And here another option, we have those vertebrae really stuck to on each other. The spinous process has a wide base, and because of that, and it's probably also not well flexed. So now, because of combination of wide base spinous process, poor flexion, and low intervertebral disc height, we don't see any interlaminar space, right? And for this particular spine, we can use any approach, midline or paraspinous approach. You can imagine you can just start in any space. For that one, you're better off using paraspinal approach and maybe even true paramedian, because you have to start a little bit lower and a little bit lateral to negotiate into this small space. So, and how can we modify the situation? This one, for example, is just better position, because if we flex the spine, we might open up the space a little bit more and make it possible. So let's talk about position. So those are goals of good positioning. First, we have to avoid any side bends and rotation, because all this will kind of throw you off and you will not even know where to go. You can imagine if you palpate this and try to do, or palpate this and try to do epidural, it will be very difficult. Then you try to open those spaces as much as possible. See how we can go from regular position to good flexion, and space between spinous processes and interlaminar spaces open up significantly. And a third goal is improve ergonomics for both, for patient and for operator. So this is just illustration how optimal flexion affect interlaminar space or interspinous space. So this is before good flexion and this is after good flexion. See how all the spaces are open up. So I cannot, overemphasize how important is good positioning and good flexion of the spine. And here another view from a side. Now pay attention to interspinous spaces and good flexion, and they open up drastically and you can completely change the situation. So what are the tools of optimal positioning? So adjustable bed, better if it's narrow than this wide ICU bed because it becomes difficult ergonomically. Positional chair, and I highly recommend for you to purchase one like that. It makes a big difference. Extra pillows, extra step up so you can adjust your height if needed for ergonomics. 2-inch tape, and we also recommend those visual aids for the patient. It's much easier to show them picture that demonstrate what you want from them than explain sometimes. And of course, assistant is extremely valuable, and assistant may provide physical support for patient. Just pull the elbow forward. Moral support for the patient, like works better than sedation, and of course IV sedation. So lateral versus sitting. So if possible, we always try to sit the patient. It's just much easier to achieve all these goals of positioning if patient is sitting. Sitting is also great for hanging drop technique. We don't use hanging drop for lateral position. And unfortunately, we occasionally must do lateral. Let's say pediatric epidural in OR under general anesthesia, post-op epidurals, ICU patient, and as expert you have to know how to do it. So that's why we're gonna practice epidural in lateral position as well. But I want to show you how this sagging midline effect happens in a big people. So this is what you would feel, and imagine if you just go by landmark perpendicular to all plane, you see how far you are from midline. So in all these cases, it's extremely important to use ultrasound and try to figure out where's the true midline, not this skin sagging midline. Tips on position when patient is lateral. So use extra help, extra tape, extra pillow. Bring patient closer to the edge so you don't bend forward. Adjust height of the bed. Consider chair for yourself. I think it's better to gown if you think that your elbow will be resting on a bed. Be cognizant of this inadvertent spine bends. So that's not uncommon when spine is bent like that when patient is lateral. And be common this rotation when patient is on the side, somebody pull forward trying to kind of flex the spine, and instead of that we add rotation to the vertebrae. So remember about that. And again, one more time, you cannot use hanging drop when patient is lateral. It becomes less sensitive. It's possible, but in a lateral position we prefer loss of resistance. So that's how lateral position should be done. So shoulder over shoulder, hip over hip, nice flexion. Use pillows. You use pillows to hug. You use pillows under the head, and make sure there is no pull, and back is perpendicular to the bed. And another good trick, have your assistant to confirm that your needle is perpendicular to all planes. So, but again, most time try to use chair. Chair is excellent, and learn all this little adjustment on a chair. And there are still some tricks. So this patient is sitting, this kind of a demonstration, and you can see how back is actually extended versus proper flexion. So how do you do it? So first you ask your patient to scoot back, then you bring your chair towards the bed, pull your chest support, belly support all the way in when you do this, and bring chair close to the bed. And when you do this, make sure that this particular part, it's a limiting part, is as close as possible to the bed, right? So it should be either underneath of the rail or above the rail. It steals about 5 centimeters if you don't do this. And your chair should be as close to the bed as possible. Then when chair is brought in and brakes engaged, you adjust the height of a chair. So the chest or torso support is somewhere at the level of the epigastric level. And after that, you ask patient to scoot back toward the chair as much as possible. And when patient is as much as possible back, you engage this torso support and push it to get the perfect flexion of the back. So let's talk about practical point, choosing the level. So it depends what is the surgery. If it's chest, T45. If it's upper abdomen, 7-8. And if it's middle lower abdomen, T10-11. So very easy to remember, 4, 7, and 10. What is anatomy like? If you have two spaces close to each other and one is big and one is almost impossible to get, go for the bigger one. Remember that epidural in upper level has more tendency to spread down, and in lower level it has tend to spread more cephalad. So there's a little bit of forgiveness where you choose. And if you choose to deviate from whatever your original plan is, and especially when you do this for ears, you rather avoid lower levels like T10 versus, let's say, T12, right? Because otherwise you're going to end up with lower extremity weakness and bladder issues. All right, let's talk about palpation. So when we position patient perfectly, we're going to use palpation. Even if we use ultrasound, you use finger over finger if patient is big, and you outline spinous process, and you do it more than one level to kind of appreciate the trend. See if there's any deviation from midline, see if there's any increase in distance between the tips of spinous process. and eventually we're going to combine surface landmark with ultrasound marking. All right, so this is our surface landmark based on palpation. And so now the question is where to have entry level, right? And so you can, if we decided to do parasagittal, paraspinous approach, like we said, one of the best, we have to decide how far from midline, this will be an x-axis, and how far cephaloidal chordate our entry point should be, right? And so if we look at this, if you imagine this level, so theoretically, if we go paraspinous at the upper part, everything will be all right. But if we apply same approach to next level based on just palpation, you see that we can actually end up in an interlaminar space on the first try, especially if this, you see this spinous process a little bit deviated. So that's why it's much better to use ultrasound. And we'll take a break, and after break we will continue with part 2 and discuss use of ultrasound. Okay.